platform, ND has pioneered the development of digital healthcare solutions, making quality healthcare more accessible and more convenient. Under his leadership, Practo has expanded its services to cover online consultations, health records, and a lot more. A hearty warm welcome to you, sir. I also now take the pleasure of welcoming Indu Bhushan, President, iLEAP, ex-CEO, Ayushman Bharat, National Health Authority. Indu Bhushan is the President of iLEAP and former CEO of Ayushman Bharat, National Health Authority. Bhushan has extensive experience in healthcare policy, strategy and implementation, while she has played a crucial role in designing and implementing Ayushman Bharat, India's flagship healthcare program. Ladies and gentlemen, let's give a big round of applause and let's welcome Mrs. Indu Bhushan. Dr. Sonal Asthana, our moderator for this session, Clinical Lead and Program Director, HPB and Multiorgan Transplant Surgery, Aster Integrated Liver Care Group and Aster Group of Hospitals. Dr. Sonal Asthana is the Clinical Lead and Program Director of HPB and Multi-Organ Transplant Surgery at Aster Integrated Liver Care Group. Asthana is a renowned liver transplant surgeon, while with their medical expertise and experience, they moderate sessions and healthcare and a lot of medical innovation that's been done under his leadership. Ladies and gentlemen, let's give a big round of applause to all our dignitaries on stage, and I leave it to Dr. Sonal Asthana to take the discussion forward.
Good afternoon. It's a pleasure to be here today, and welcome all to Invest Karnataka. I must thank the authorities for giving us the opportunity to discuss this very important thing. Of course, this is Bangalore. You have to discuss digital innovation because this is where it all started, the Silicon Valley of Bangalore. And today we have three eminent panelists. So we will have a discussion that follows some structure, but obviously we'll take up interesting points as they come up. And hopefully at the end, we'll have some time for questions as well. So digital health and innovation is obviously the big, probably differentiator that we are looking at that will change the trajectory of Indian healthcare from where it is right now. It is an enabler, it will help us to scale and hopefully improve equity and access as well. So today's discussion is divided into three parts. How digital innovation will affect systems, how it will affect providers, and thirdly, most importantly, how we can make these innovations accessible and scalable for patients. So the first part today, we'll talk about digital innovation and systems, and we'll start with Dr. Bhushan sir. Actually, he's the man behind Ayushman Bharat. He's perhaps the first fundamental shift in Indian thinking where the government has moved from a provider of healthcare to a payer of healthcare as well, which leverages existing capacity in India in the private sector, which makes it accessible to the common man as well. A very important corollary to Ayushman Bharat was the Ayushman Bharat Digital Mission, which actually laid out a blueprint for how digital innovation could be part of the AB system. Now, we've had excellent impact assessment of what AB has done for healthcare in the country. But I would like to, my first question would be about Ayushman Bharat Digital Mission, sir. So do you think that Ayushman Bharat Digital Mission has achieved its objective of equity and access, and if there have been challenges, what have they been?
So thank you, Sonal, and thank you for inviting me here. And as far as Ayushman Bharat Digital Mission is concerned, abhi to party shuru hui hai. Abhi to, I think it's a very early days, and Ayushman Bharat Digital Mission is extremely complex mission in terms of implementation, and usually people draw parallel between fintech and health, digital health. But I can tell you that there is nothing in common. In fintech, you have very small number of banks, maybe 100 banks, and you have large number of people who are actually invested and they want to be part of, they want to use fintech. And their vendors and traders, they are also very keen to support fintech because they are gaining from this. But in digital health, we have large number of hospitals in thousands. We have many other labs and many other providers. And we have, of course, large number of patients, and they vary from being very sophisticated to rural patients. And there is no convergence in terms of interest. When I was starting Ayushman Bharat Digital Mission, it used to be called National Digital Health Mission, NDHM at that time. We held a large number of meetings with the providers and of course with others too. And the first question that they would ask me is that what is in it for us? If we make all these things digital, how is that going to be helping me? Number one. Number two, especially from doctors, the question would come that, you have to come to our clinic and see how much pressure that we have. And on top of that, you want us to digitize our record and put everything in your computer. Should I be looking at the patient or to the computer? And of course, there are answers to all of these. But in terms of acceptability, there is still a big problem. And we have some large corporate hospitals represented here, and probably they wouldn't have a problem. They already are aligned with the Ayushman Bharat Digital Mission. But there's a large number of small hospitals and clinics who are not aligned with Ayushman Bharat. It will take a long time for them to get aligned. Also, there's a capacity constraint in our curriculum, in our hospital, in our medical education. We talk about bedside manners, but now we have to tell them about website manner, because we have to train our providers in terms of, unless that happens, there will be, I think, a problem. There is a capacity constraint among states and among health sector that has to be addressed. And as you, I think, alluded to, there is a equity issue here as well. The access to digital technology is inequitable. A large number of our rural households don't have access to smartphone, not even smartphone. Some of them may not even have phones. So connecting them also will be a challenge, and that actually has to be looked into. So, but I am convinced that new technology with AI, many of these constraints can be resolved, and with the focus, probably in 5 years' time, and maybe before 5 years' time, we'll have same kind of ease with which we do right now using fintech, Google Pay, Paytm. We transfer money, we'll be transferring our health records and seeing our longitudinal long-term health record, and our diagnosis will be based on those records, and it will be interoperable. So I think it's a difficult thing, but we need to stay the course.
Sure. Now, thank you, sir. You summarized some very interesting points. One was obviously the resistance on the part of caregivers to change their ways. And the second is the access difference between the rural and the urban population, among the many inequalities that are there. So as a follow-on, I'd like to ask you one question. As in, do you think that in the short term, adoption of digital health may exacerbate these differences, between the haves and the have-nots? And is there something that we can do from an AI perspective that can make that easier?
That is going to happen. That is going to happen. And, I was attending one of the sessions this morning, and one of the speakers said something which was really interesting. People say that future is already here. It's only that it's very inequitably distributed. So, of course, we have hospitals where digital technology is working very well. They are sending us report within time. They're linking our reports to the previous reports. But again, there are others who are not doing this, or other patients who are not receiving the same service. So obviously, in the initial phases, there will be divergence. But once we have a critical mass, once they are payers who are insisting that we should have digital record because it's easier to monitor. And I can tell you that in all countries where digital health has taken root, it's largely because insurance companies and payers have insisted on this, because they have a vested interest in ensuring that all the records are digital. So I have no doubt that, of course, there'll be trajectory where there'll be a divergence, and in economics we call it Kuznets curves, that first inequities will increase and then they'll converge. So that's going to happen.
Thank you, sir. I'd like to move on to Dr. Ashutosh now. Obviously, Dr. Bhushan has a very high opinion of private healthcare being much more organized, but at least I can put up my hand and say that that's not always the case. We know that there are probably challenges that need to be overcome. Now, Fortis is known to be a very systems-driven organization, and it's well regarded in the industry for that. My first question was, what in this entire process of healthcare systems is not digitizable? You know, what is the part that, in your view, cannot be handed over to the machine? You know, and it has to be kept or have human oversight.
You know, touch was considered as one thing which cannot be digitized, not anymore. So we don't know the limits of technology and we don't know where it is going to go. I don't think I would like to hazard that which part of the medical care will not be technology dependent. If not completely shifted to technology, at least dependent on technology. Everything in medical field, the adoption of technology in delivery of care was quite slow compared to adoption of equipment which was of very high technology. So there, that difference was always there. I think one of the things which is important to understand is that though I appreciate the point that, you know, that private healthcare probably has done better on digital, but I think there is a lot lacking there. And certain belief I have, which is that public health infrastructure and the public health policy will drive the digital adoption. Eventually, you need a standardization, you need interoperability. Once you have that in the medical records, then you have linear records of all the patients. There is so much you can do with that data. You can predict the disease, you can predict the prevalence of disease in a particular geography, you can look at possible outbreaks of disease or the future requirements of infrastructure you can predict, and that can change the whole paradigm. Otherwise, there's so much wastage in the system. Generally, what happens in the private sector, that way I would say the government sector, public sector is much more organized because repetitions don't happen. So the wastage is minimal. But in private sector, what happens is patient goes one place, does some set of investigations, then they go to another place, they do another set of investigations. By the time they come for the procedure, they've sort of exhausted all their financial resources. So I think there are a lot of challenges, but I think I completely agree with what Dr. Indu Bhushan said, that, you know, this whole catalyst of the digital health mission and the Ayushman Bharat is going to transform healthcare in the country. But it's not going to happen in a short time, but this is just the beginning. And unless until the policies are such, and one of the things which will drive this also, I believe, is the payer mechanism. Earlier, patient was the payer, but now gradually that is shifting and there is an intermediary. There is some other payer, either government is paying or a private insurance company is paying or your employer is paying. So the scrutiny becomes more. And that sort of encourages for medical records, etc. But medical records is one part. I think what is also very, very important is, especially the generative AI and all other these technologies, they are going to transform the personalized care. Genomics is another area which is going to transform the way cancer care is provided. However, that would require a ecosystem where the data is flowing linearly, it is interoperable, it is accessible, and that part is very, very important. So I believe that this whole initiative is something which can thrive only if the public side of the ecosystem leads it. Of course, private sector has to follow and collaborate. That is very important as well.
Sure. Now again, very excellent points. I think there are 2 points that both of you have made. One is a critical mass of adoption, because there has to be a critical mass after which your exponential curve starts, where it becomes easy for data to flow. And the second thing that, as you very correctly pointed out, is that it has to be a public sector driven initiative, because unless it's driven from the grassroots up, the private sector can't necessarily take a lead for the reasons that you mentioned, because perhaps not everything is dependent on market forces actually in these situations. So in terms of digital adoption, like for example, within your own organization, how does digital innovation affect scaling? Because for example, now Fortis is a large organization, has hospitals across India. So how would digital innovation enable scaling of the provision of healthcare?
I think that's a very important thing, to bring in efficiency, that technology can play a big role. So we operate hospitals in various parts and also in some of the smaller cities where sometimes the manpower is a challenge. Skilled manpower, or people want second opinions. So digital radiology and digital pathology is something where we have been able to use technology quite effectively. We have been able to report remotely from our one hospital to the other, and if the radiology is not available, especially the night scans and all that, we have been able to achieve quite well. However, our journey has just begun. We believe that a complete paperless hospital is mandatory. Every single record, every single transaction, whether it's a financial transaction or whether it's the care part of it, everything has to be digitized. If that level of record and data is available, then you can draw so many conclusions from it, and you can build in so much of efficiency and quality. You can improve your outcomes at a value which the society can afford.
Sure. And again, incredible point that when you take up digital innovation, you don't have to reinvent the wheel each time, and don't have to start services from scratch. There are many services that can take off at a tertiary level even without having to wait for the lag time. So certainly adoption would accelerate scaling in many ways actually. So that is an excellent point as well. Mr. Shashank, I'll come to you. I mean, the question isn't related to Practo as such right now. I'd like to talk to you a little bit about the work that you've done in iSpirit before. So, you know that one of iSpirit's greatest success has been in creating the fin stack. Both Dr. Bhushan and Dr. Ashutosh have actually referred to that. And, it's really changed the face of how we do business in India in terms of financial transaction. So what can the health stack learn? What are the lessons that we can learn from the financial stack, which will enable sort of transparency and ease of digital adoption?
Thank you for that question, and it's good to be here. Yes, I was part of, I was a very active volunteer at iSpirit and still very keen to support the DPI initiatives in India. I think the healthcare, I've done the Practo for now 16 years, right? And I've seen healthcare up close as a technologist from outside, and now inside healthcare and spending 16 years in healthcare. What I can tell you is that fintech and health tech, or you take any e-commerce for that matter, or any tech, you put any industry and tech, there are only three real benefits that technology offers. It's either cost reduction, it's either convenience, or it's improvement in quality. If you look at fintech, the main thing that what does UPI do for all of us? Why do we all use UPI today? Because it's convenient, it's very fast. And that aspect of value proposition of fintech is what attracts all of us. Unfortunately, in healthcare, we don't go to the doctor who's available the next minute, right? So convenient, we'd all waited for half an hour, or even 15 minutes, or even 1 hour, 2 hours for a doctor. So convenience as a value proposition is important, but not the first one. So what is most important in healthcare? the most important thing in healthcare is quality, and quality by a far distance. And so the main proposition in healthcare that all stakeholders, be it hospitals or be it diagnostics or pharmacies or digital players like ours, we all aspire for is how do we improve health outcomes in a cost-efficient manner. Now, the job of any tech, health tech or any stack has to be that how does that contribute to improving health outcomes in a cost-effective manner. Till we answer that question, it will still be unresolved, right? So if we solve the problem of digital records, for example, it's a convenience problem. So value proposition is good, but is it as strong as a UPI's convenience? Not really. So that's where I think we need to increase the value proposition of health tech, and health tech companies, including ourselves, have to be able to demonstrate how does technology improve health outcomes and making it more cost efficient. Now let's look at the second example in UP and fintech. What's the second most important thing that fintech has done? First one was convenience. We all use UPI. The second most important thing they did was they are able to increase the credit worthiness of individuals, the access to capital, and reducing the cost of capital to each one of us. If you take the comparison to healthcare, that's how do we make sure that for the same quality of care, can we deliver it in a more cost-efficient manner? Unfortunately, in today's healthcare delivery system, pricing transparency is really not there, and hence that benefit is not available as well. So if I would draw out how does health tech or other health stack solve problems, it has to solve quality. I would say 70% or 75% of the weightage has to be there. 20% of the weightage has to be in making healthcare cost effective, and 5% weightage has to be to make it convenient. And today I feel that we still need to arrive at value propositions that can actually deliver on these three.
Just to I think maybe go against what you're saying. Health tech and the kind of work that you've done increases convenience, because earlier I would go to a doctor with this thick of file, and sometimes some of my records were missing. And now with these innovations, I just go with my iPhone or just a number, and those records can be just pulled up. So in terms of doctor having the entire background about me, that's very convenient. And also I'm hoping that if that is the information that he or she has, he or she will also be diagnosed me better, right? In terms of quality of care will also be much better. And earlier, probably the doctor, the provider was diagnosing things out in blindness, like with a hazy background, hazy information, right? So now the quality should also improve with these innovations. So I think it's a chicken and egg situation. As health tech becomes deeper, we'll start to appreciate the importance of health tech and the convenience and the quality it provides.
So actually, I have a counter to what you said, Shashank. Because this is a real example of Practo. I was visiting a friend in Malvan, which is north of Goa and on the Konkan coast. He runs a small practice. So we were chatting, and there were some papers on his desk, and I suddenly saw a lot of Assamese names. I said, this is interesting. Do you have an Assamese community here? So as it happens, he does a lot of digital consultation for patients from Assam. So people who have coughs, colds, they don't have time to go to the doctor. He logs on between 11 and 1, and off he goes, right? He does the consultations, sends them a prescription, and it's done. And because of that, he's made a name for himself in Assam, and a lot of people consult him because, the neighbors have said that he's good. Those micro-environments develop for doctors, as you know, because one person says you're good and you go to the same doctor. So this is an interesting example how convenience trumps everything, actually, because somebody sitting in Malvan has a practice in Assam, which would not have happened without your platform, as it happens, So
trust me, I love my platform. But I think just to be slightly more, relatively to what it was 10 years back to today, huge transformation. But I'm just looking at it from fintech, because the question was on fintech and this. And if you look at fintech, the speed of adoption and the percentage of the industry that has got digitized versus what we're talking about healthcare is different. So we are, in fintech, we are looking at very high double digit, and if you look at the numbers at which the growth rate has has been phenomenally high. I think in health tech, we have still been not able to demonstrate that same level of...
Shashank, we should never compare health tech with fintech at all.
That was my bad. That was my question, actually.
In early 90s and late 80s, all the banks were digitized. We used to do internet banking, right, in 80s and 90s. Everything was digitized. And for one good reason, because in health, in fintech, there's only one metric, money, right? And it's very easy to digitize because actually it's already digitized numbers. But in health, you have many things. You have things which are measured in millimeters. You have things which are measured in terms of pressure. You have things which are measured in terms of some percentage of something. And you have images. You have MRI. And there's so many things that need to be digitized, which are very complex. And it's difficult to understand. Maybe there are about thousands of things which need to be digitized. So I think fintech and health tech are very different, and we should not compare it. And also, second thing, fintech, the journey started in 2007 with the NPCI, right? And it actually got a huge fillip because of demonetization. Demonetization happened, and there was a lot of interest in fintech and payment. And after that, COVID, because then people didn't want to pay in cash because of fear of infection. So there were two shocks which actually helped fintech. So I think let's not compare them at all. They're apples and oranges. I would say that they're apples and maybe bullock carts.
That's excellent. I think Dr. Ashutosh also pointed out that adoption scales are different, and certainly healthcare lags behind the real world by at least 2 decades, in my opinion, when it comes to, because physicians are naturally conservative. If something's working, I'm not going to change it. It's my surgical practice or medical practice. If you know that a medicine is working or a mechanism is working, we are reluctant to change it because change isn't necessarily always better. So now, I mean, on that light, when Dr. Bhushan was talking, I was thinking about multimodal LLMs as well, because trying to piece together data from different sources, images, reports, etc., to come out with a coherent picture. Now, we know that AI is also linked to security and national identity in many ways. So how does, this question is basically to both Dr. Bhushan and to yourself. Firstly, what special measures should we have in place? Because on the one hand, we want to learn from the world and adopt AI and adopt best practices from across the world, but we also want to make sure that our data is not misused and there is a security wall in some way that protects our patient information. And secondly, that should we go down sort of the EU route and push for regulation before it's actually happened? So,
well, answer to the second question, of course, is no. I think you framed in a way that, and I'll come to that later. But security and privacy is a major issue for health sector. Health data is sensitive, and it has to be. We need to ensure that it is not leaked out. And we, luckily, with the DPDP Act, for which was approved by the Parliament last year, but the draft rules came on 3rd of January this year, and they are going to be finalized soon. So that defines very clearly what are the roles and responsibilities of data fiduciary are, and how the data should be collected based on consent, informed consent, how it should be stored, how it should be shared. And all that rules are now going to be in place very soon. And in terms of AI, of course, because AI is based on large amount of data, there has to be some rules in place for that. One should be that data should be used in a federated manner. We should not be taking data and centralizing it someplace, which is also the philosophy underpinning ABDM, that we keep data in a federated style, not centralized data, because that has a huge potential of leakage. And there has to be a strong protocol in terms of security, but also access to data. That has to be very clearly done. And in terms of reporting any leakage and taking action where it is because of negligence. I think that is where probably the importance of the rules will lie.
Sure. Shashank.
Yeah. I'll again go back to, I think the technology is very new. And, the thing that I get up in the morning and think about and go to bed with is how do you improve health outcomes in a cost-effective manner? And I don't know how many of us here have used O1 Pro model. The ChatGPT's O1 Pro. Has anybody here used it? O1 Pro. Like 2 of you, right? 3 of you. And I can tell you, I've been using it for the last, it just got out a few months, maybe a few weeks, a few months back. And it is I used ChatGPT since 22 November onwards. I used this in the last 3 months, and I can't find a question that I'm not able to be wowed by, right? Because when I ask ChatGPT a few questions, I am still disappointed sometimes. But the kind of product that O1 Pro is unbelievable. And what's the difference? What's the difference between the normal ChatGPT and what does the O1 Pro do differently? The normal ChatGPT gives you a response within a few seconds. The O1 Pro thinks for a few minutes. And when it thinks for a few minutes, I'm using things, but actually it processes for a few minutes, and the kind of response is unbelievable. So we have internally been using some of these models to see how consumer engagement goes on our app. For the last 1 year, we've been having consumers use this, of course, with safety guards to make sure that A, data is with us and data is inside Indian borders, and B, that we only solve the more basic questions, nothing complex, so that there's no risk to the consumers. And we've been blown away by the kind of conversations people are having. The kind of conversations pregnant women are having with the bot is unbelievable. I know we are seeing this and seeing that they're having conversations which are run into 20, 30 long conversations because they are anxious about, should I feed this to the kid? They're very small things, right? But very important things for them. And they can't ask their mother-in-law or mother because the food that they're feeding is something that's new, right? So these are something simple, but because of this anxiousness of a new parent and mother, I can see the depth of conversation that are taking place. So where I was going with was that the value of this product, of this intelligence is still emerging. I think we need to harness it. India is doing 3 crore surgeries, which is largely what the healthcare delivery as an ecosystem delivers beyond many other things, but as a biggest output. We are probably, I'm sure, you probably have better data, but we are probably only 50% of all the required cases are being operated upon. Now, if this intelligence is able to help people navigate themselves to the right provider and is able to unlock that remaining 50% misdiagnosed or underdiagnosed cases, it's huge benefit. And at the same time, there are a lot of over-treatment that's taking place. If we can curb that, where the required people with the infrastructure that we have built, some world-class infrastructure that we built, the required people get it. It is transformational. It is absolutely transformational.
I think the question basically was, there's no doubt that the convenience factor rules. The question was about security.
And
so
last time I answered your question,
my question was that if you can see their chat, that means that you're not giving them privacy. It should be, you should not be able to see that chat.
No, I think that you're on a couple of technology companies as well. Anonymization is a great tool that one can use, and without any harm to any PI information of both sides, you are able to, and that's how even all technology products are built, is by understanding usage and usage patterns and understanding where are the consumer needs can be better solved. Sure. But I know I cited because last time I answered your question about fintech versus health tech. I think I said, okay, let me just talk about
it together. I think these should have been separated with Dr. Ashutosh. But the question basically is that there is convenience and there are certain tools that we have, like say 2-factor authentication, right, in finance. Now, is there anything specific that could address security needs for healthcare while keeping the convenience, for example? I guess that's the challenge that, say, how would you do it in Practo? How would you do that in Practo?
I think the first thing off is that nobody in Practo has access to PI information.
Agreed.
That's absolutely basic. And second is we make sure that all our data resides based on the 2 laws that have come through. One is the Data Privacy Protection Act, as well as in the healthcare specifically, there are specific laws that are there that you have to maintain. So all our data is localized internally. The third, on the consumer side, is that we ensure that from our DB architecture, how do you make sure that data cannot be hacked? That is the biggest fear that any technology platform has. That how do you make sure that whether it's injections, SQL injections, JSON injections, JavaScript injections, I'm not going to name different types of threats that a technology architecture can be exposed to. So how do you make sure that happens? Because, and just like in the case of a doctor or a hospital, you trust the doctor and the hospital with the right diagnosis. You trust a digital platform with the safety record that they have. So if thankfully, touch wood, 17 years we've had a clean record, and that's one of the reasons why we've been able to move forward. So I think the ecosystem also plays a role that if you are able to manage your safety, security in place, it also leads to a commerce model for you. In fact, and those who are not able to have to pay the repercussions for that.
Sure. No, thank you. Those are well-made points. I'm going to move on a little bit to how digital innovations will affect healthcare providers as well. So the next question is to Dr. Ashutosh. We've talked a little bit about interoperability. That we discussed also that in chains, even within the same chain, like an Aster or a Fortis, it's often very hard to have interoperability at even basic levels of laboratory, etc. Now, what would you like to see as sort of a coalition government, a common minimum agenda when it comes to interoperability for healthcare data? Because Dr. Bhushan also made the point that, say, he goes somewhere and he has his record on his iPhone, but if the record is linked to Apollo, he cannot go to Fortis and show that record. So how can we actually make sure that data is interoperable, and what kind of basic standards would it need? I'm not talking about the technical part, but what would be the basic standards that we should expect of an interoperable health record?
Yeah. My understanding is that the way the architecture of ABDM is that the data doesn't need to be interoperable actually. The data resides in various formats, whichever it may be, and say suppose I go there somewhere, show my ABA ID, and I have some records from Practo, some record from a hospital, some record from a diagnostic chain. All those will be visible to the doctor. But the problem with that is that linearity which one expects in terms of data analytics, that is not available. And I think that for that there will have to be some, as you rightly put, some common minimum program which will have to be done. I am not too sure how it will look, but I believe that at least some of the things should be standardized. One of the initiatives which has been already taken, and I think the in principle decision is there, is that SNOMED CD is to be used as a standard for the nation. I think these simple things are the minimum which should be there. If that is there, then this data becomes interoperable.
Yeah, from an end user perspective, that's absolutely correct.
Yeah.
So also one of the, yeah, please.
Dr. Raghuvanshi, I'll just mention that, with the AI coming in, the ability for unstructured data to be so, for even the ABDM's data to be utilized by this O1, if you just feed all this ABHA ID to the O1 Pro, of course with the right user consent, the kind of linearity and the longitudinal record that the O1 Pro can create would honestly solve for, even if it is in different ICD-10s and SNOMED and this thing, it would be able to make, the intelligence is so good today that it will be able to make that report. The only problem is for the company who does that, there's no incentive. So that's the real challenge I see, that the incentivization is at the provider end, the incentivization at that layer end is not there. So that's one of the challenges that we see, that layer requires some investment, it requires certain, this thing which there's no real direct economic interest right now to make that happen, in my opinion.
Yeah. No, Dr. Ashutosh, if a doctor can see all the records which are there, whether they are in lab or hospital or Practo, that itself is an interoperability, because people can take and so long as everyone follows the same standards which are prescribed by ABDM, records by definition will be interoperable. But of course, not all records are digitized, not all records are following the same standards right now. And of course, because ABDM is not mandatory, it's based on your own will, I think it will take some time. But once everyone is following the same standards, they will be interoperable. And one thing I can say that I'm not talking about your hospitals, but one reason providers don't want to use digital health is because they don't want to be accountable. Because if there are doctors, for example, who are prescribing unnecessary antibiotics or unnecessary tests, they don't want to have it on record through digital means, because right now when you do it through paper, it's very difficult to audit that. But through digital health, you can see that this guy, this doctor always prescribes antibiotics irrespective of what kind of ailments the patient comes with. So they'll be more accountable. So they don't want to be accountable in many times because in response they're not getting anything which will help them, right? And same thing with interoperability, because many hospitals don't want to want the patients to leave the hospital and go to the other hospitals, and they would like the records to be with them, and this is the reality. So I'm not casting aspirations on any of the panelists or many hospitals, but that is the reality that we face.
So I mean, that's definitely, I agree with you that the resistance which is there, initially it was more and it is gradually waning, because once people realize that there is no choice, then they are okay. But sir, I have a question for you, is why is ABDM not being made compulsory? Can it be made compulsory?
Well, that will require a law from the parliament, and because we can't enforce things and I think there are Supreme Court judgments on this, that even for creating ABHA, you have to do it only if patients agree to it. It's based on informed consent, and things can be made compulsorily if it's in public interest. Here we're talking about private interest. It's interest to the person that you should have ABHA ID, you can link it, and therefore it's a legal issue. So unless there is a act which is passed by parliament, you can't do it. You can't enforce it based on. And second issue is that health in our country is a state subject, and each state has to have its own rules and laws. And if you mandate it from national level under the constitution, states can refuse to follow it. So I think it will take time, and I don't think mandating it is a solution. Frankly, you have an iPhone, I have a phone. We're not carrying it because it's mandated. We're carrying it because we can't live without it. So let's make digital health so good that people will work on it, providers will gain from it, patients of course will gain from it, insurance companies will gain from it, government will gain from it, researchers will gain from it. So everyone, it's a win-win-win situation, and so let's not enforce it, let's let people adopt it because they'll find it useful.
So I think that one credits doctors with a lot more meta-analysis than we can actually do. When I'm sitting in my OPD, I just want to get seen with those 30, 40 patients and go home. I'm not thinking about whether I'm prescribing more antibiotics or this antibiotic or that antibiotic. It's just about, doing that. I suspect that clearly there will be patterns that develop, and it will be interesting to study those patterns. And there can be some sort of standardization that can happen, at least in certain conditions, and that is useful for progress. I'm just going to circle back a little bit to efficiencies, because you would agree that healthcare, sort of consumables is probably one of the most messy situations for any hospital, because it's very fragmented, the prices that hospitals get, and there is no collective bargaining as such. And there is a lot of efficiency that could come from the digital, from a digital platform. Just for example, the National Cancer Grid has saved 70% on all cancer medication just because they've standardized procurement for hospitals within the NCG. So is there any parallel that can be done or is being done, say at a hospital level or at a hospital group level that can actually use this kind of collective bargaining, collective purchasing power to drive down the prices of healthcare and consumables and healthcare eventually?
Yeah, I think in a chain it is very, very important to do that. And we as a group, we operate, of course, multiple hospitals, and we are part of the IHH network, which operates in several other countries too. So we have a kind of a global procurement department. So we are looking at procuring pharmaceuticals and even the large capex items like cath labs, linear accelerators, etc., at a kind of a centralized way. And it certainly gives us a lot of advantage. However, what is very important in the hospitals is the clinical syndication, getting the clinicians on board. And that is a challenge. So I think these decisions cannot be driven purely by the administration. This has to come with the consent of the clinicians, and they have to be involved in deciding of standardization. So in Fortis, for example, we have about almost 90% of our items are CBU rates and centrally negotiated. And that makes for a lot of efficiency actually. So I think it is very important to make physicians part of that decision making to achieve that in a private network.
Sure. So the last 10% is not digitizable. So, I mean, when it comes to payment, again, there are a lot of opportunities that have come up from the insurance sector. Insurance sectors are obviously underpenetrated in India. There are many, many challenges with payouts, with sort of claims and so on and so forth that are dealt with by hospitals on a daily basis. So now Ayushman Bharat is an experiment that allows us to do things differently. I mean, can you think of efficiencies that can be brought in when it comes to payment structures for patients using the AB platform, because it's a big platform. So that allows a lot of leeway in terms of perhaps innovating in terms of financial models.
In terms of improving access to insurance?
That's correct, sir.
Okay, so, of course, that's something very close to my heart because I was the founding CEO of Ayushman Bharat, and I've done a paper which was submitted to Lancet, which shows that based on that data that we have from 2023, the coverage of insurance has increased from about 15% in 2018 to about 77% in now. So huge jump in terms of insurance because of Ayushman Bharat largely and state schemes, and many states have actually gone 100% coverage. So that's a big achievement, I think, which people don't appreciate. And Ayushman Bharat currently is, of course, providing 2 million treatments every month and about 2.5 crore treatments every year. So again, it's a good pickup. But your basic question is right that when you look at private insurance and its pickup, they has been challenging because what we call missing middle. Because there are some people who are not poor enough to be to qualify for Ayushman Bharat, and they're not rich enough to afford private insurance. They fall in that missing middle, and the challenge is how do we cover those people, and how do we make sure that insurance is affordable for them. And why is insurance not affordable and why it is expensive, still expensive, is because of the fundamental market failure in the insurance market. In insurance market, when you insure a person, there's an asymmetry of information. The person who wants to insure knows much more about the health condition and what they'll likely to use as compared to the insurance company. And so setting a actuarial premium is very difficult. But after you've insured a person, then the issue of moral hazard kicks in. Because then, since you are insured, you would like to use services even when it's not needed, or you like to use more services because it can be covered by insurance. But it doesn't stop there. It also, when hospitals claim money, sometimes between hospitals and payers, there is a lack of transparency, because the hospitals may be charging something which is not needed, and insurance companies at that time, because they have a asymmetry of power also, they may deny something which actually has been done. So the whole thing is broken. Here, this is here where AI and digital health can help in a big way. AI can help in terms of looking at the risk profile of the person and setting right actual based premium. AI and blockchain can help in terms of processing of claims and ensuring that or minimizing the fraud and abuse. At the same time, improving accountability, because it can show that how long insurance company is not paying the payment. So I think there's a huge potential for IT, AI, and blockchain to improve the whole structure in terms of cutting down on asymmetry of information and asymmetry of power. And I'm sure you would be dealing with a lot of insurance companies, and I think you would see that on daily basis in terms of this kind of breaking of insurance markets.
Yes, you're absolutely right. There is a complete lack of trust between the providers and insurance companies, and it is becoming worse. And I think technology can play an important part to bridge that trust deficit.
So staying on the large data and analysis part, because a platform like Practo has a huge amount of granular data coming in, and in the presence of, because of the fragmentation, so to speak, of public health care, which Dr. Bhushan also talked about and which has been discussed. Often systems like yours are probably the best placed to analyze data and even service early warnings. For example, if you get like a report of a lot of cough and cold coming from Bengal, then you could probably infer that there's an influenza epidemic. It could be an early warning sign, for example. So are you doing anything like this, or is there a mechanism by which you think AI could play a role with the data that you're getting and be useful as a public health, from a public health standpoint?
No, absolutely. I think just to give you some numbers out, we do close to about, from a transaction standpoint, around 3,200 crores. But if you look Bangalore, out of a 15 million population, close to about maybe 8 million people visit us each year. Now that's just one city. Of course, there are many cities, and so the penetration levels are good, primarily because we are, we are not an atom, right? We're on the cloud. So we have been able to see whether when there's an influenza increase, especially on the primary care side, when we are able to see when there's a breakout of a flu or a different thing in different parts of the country. So far, what we've been doing has been that we've been using mass media channels to be able to share these insights. We do one annual insights, which tells us annually whether it's mental health or whether it is different types of ailments, how they are progressing. We do an annual release of that information at an annual basis. But wherever there is episodic or rather a seasonal change, we release that through mass media. I think we do about 4, 5 such releases. But this is not very efficient. So what we are doing is we are creating, Mr. Nachiket Moore is a advisor to us. So with his help, we're creating a national portal where you can actually see the live data. And so you can, so it doesn't have to be this asynchronous, once we see something we share, but anybody can just log in and take a look at that. And we'll also have the API so that anybody wants to take this information and alert their systems, they can alert their systems. Because this is all data that's coming to us. So we are very, very happy to do that. So that's one. Second is we do have a research team internally where looking at our data, we have collaborations with IIM Ahmedabad right now and a few other research organizations where we're opening our data and saying that why don't you come and take a look at our data? You might be doing research and we might have only limited context and knowledge, but if our data can be useful to your research, please use it. And your research board can publish the paper. Of course, all of this is keeping the privacy and anonymization intact. And so we have opened up our data to a bunch of research. Actually, tomorrow IIM Bangalore team is in office taking a look at how we can collaborate with them. So the idea is that this information is just happens to be at Practo, but ideally they should be used by anybody and everybody to be able to improve alert mechanisms for the country or research of theirs that they can take forward. If somebody is researching on pregnant women or are researching on elderly and they want to use our platform to access elderly patients, we're very open to it and saying that you access the elderly patients and a cohort and see what you want to do, recruit patients from us. We are seeing close to about each year 150 million patients coming to us, and so very happy to do more. And also just to call out, I think digital health, I think people might not be aware of this outside, is that we did not have even a single profitable company. Right? Now, profits are important because for sustained innovation, profits are very important. Even though the industry has been on since 2008, we didn't have a single large-scale profitable venture. But now that is changing. We've been profitable now for a year plus. Many more are becoming profitable. So when that happens, you'll see a next cycle of investments back into technology. Lesser short-term investments, more long-term investments. More patients, more patient capital coming through. You'll start seeing digital companies going public. That allows for further cycles of innovation, longer cycles of gestation of period of capital, cheaper capital cost, longer investment. So I think unfortunately digital healthcare is completely agreeing with Mr. Indu Bhushan that healthcare is the last industry to adopt technology.
Maybe we should change places.
Last industry to adopt technology. I would call a victim of that, but it's just how the industry is. It is how it's supposed to be because life is the most precious thing, and you should not, there is reasons for it. But it will just mean that if any other industry took X years, healthcare will take 5X years or 3X years. So you will see these cycles of innovations coming through, and so digital health companies will be more than ready to share more information, do more research, and be able to offer more solutions towards national good.
So do you think this is a place where public-private partnership would be helpful? Because this data is useful for public health planning as well. So, like working with, say, the government of health in Karnataka or the government of India.
That was my question also, that is it possible to link this with, say, ICMR? Because ICMR also is mandated to do the surveillance and see what is happening in the whole country, and you have a gold mine of this data, and I think that would be wonderful. But also your initiative to share that data with these researchers is also really remarkable, and probably I'll come to you for seeking access to this data. So.
Absolutely. Just to call it out, ICMR has just had a new IISc division that's looking into this research, and we've been trying to break through. IISc itself has a lot of forts and walls in it, but we've been able to break through to 2-3 departments in IISc where we have been able to break through. But it'll be great if, honestly, we have maybe a single window or somewhere in which this research can take place more actively. Today it's siloed, and each company has to break the walls independently. But if we are able to, through maybe Ministry of Health or maybe NHA, have some kind of meeting ground of these two, there can be more matches. Practo is just one of the so many digital companies, and there are so many others on the other side doing research. If we can join these hands, we will be able to do far better research. Today, we are taking pharmaceutical products that are made for Caucasian people. We are taking diagnostic tools that are built in Western countries. Our indigenous data can build indigenous solutions. It just needs that collaboration. I would only say that digital companies were not coming forward because of time, monetary constraints. Now, when they are becoming more profitable, I think they'll be more willing.
Certainly, at a academic level, like ISC, I'm an adjunct professor at ISC. Certainly, that can happen. Because there are people who would be interested in looking at the data from a modeling perspective, and from a public health perspective, ICMR and public policy ministries of health would be interested in that kind of data as well. And that I'm glad that you brought it to the patient, because the last part of our discussion will be focused on what all this means for the end user, the patient, eventually. Dr. Bhushan, now we know that healthcare is devolving, so to speak. It's moving out of hospitals. You have virtual agents. You have care at home. You even have ICUs at home. Now, to a large extent, corporate hospitals are more nimble because they can actually adapt to, say, a whole home care atmosphere or a mechanism by which continued care can be given. How do you think the AIIMS of the world are going to adapt? How are the academic centers of the public health hospitals going to adapt to this? How do you see them shaping up?
they'll have to change. They'll have to change because, as you said, that the future is largely home-based care, and hospitals are going to be providing very specialized care, which is surgeries, complicated surgeries, and very specialized procedures. Because what is happening is that, why do you go to the hospital? Although none of us want to go to hospital, it's not the best place to go. But we go there because we can't consult remotely. Hospitals can't monitor your health conditions remotely. And for many diagnostics, they can't be done at home. But now all that is changing. With telemedicine, they can consult you remotely. You can now, many diagnostic tests are more nimble and mobile, and they can be done at home. And your conditions can be monitored through IoT devices. So in that sense, home care will be much more pleasant and much more cost effective, especially with now burden of disease going to non-communicable diseases where long-term treatment is needed. I think there is no other option but greater focus on home care that will happen. So once that happens, then obviously the kind of services public hospitals are going to provide will change. I foresee AIIMS, instead of having long queues of OPD lines, there will be some computer terminals where you can go and check things through use of AI. And if there's a problem, you can see the doctor. But also there would be war rooms kind of places there where doctors will be monitoring health conditions of thousands of people which are connected through IoT devices, and they can see if someone needs urgent care or not. And there will be rooms for providing teleconsultations. People, instead of coming physically, getting consulting based on telemedicine. Also, there will be greater, I think, cooperation and coordination between specialized tertiary level and a lot of small primary health care, because the primary health care doctors and clinics will provide the services on the day-to-day basis for majority of primary and secondary kind of health care. So that structure will change in terms of how it connects to various parts of the and much less fragmented, but also the kind of services they provide.
Sure. Thank you, sir. So, Dr. Ashutosh, I'll come back to something that you had brought up in the early part, that is personalized medicine and genomic medicine. So now, we are moving in the big data information age, and again, I guess corporate hospitals, private hospitals are the best place to process that in a way because of the speed at which they can move. So, how do you think that say personalized medicine is going to impact care delivery, for say tertiary or quaternary medicine?
Yes, so I think it is already there, and but it is not scaled. So at the moment, these therapies are very expensive. CAR-T cell therapy, for example, was very expensive, but now there are a couple of companies in India which have developed the solutions, and I'm sure there will be more. And the price has come down by almost 5 times. So once it becomes more affordable and is scalable, then I think it will be available to more people in the community. Private hospitals, I think, can do more in terms of collaboration with these setups and various other innovations as well. So I think that is where the tendency of the corporate hospitals typically is to be very insular and to look very inwards. They tend not to collaborate so much. I think the time today is to collaborate because these things are very niche specialities and very niche areas of expertise. You cannot acquire all those expertise in one organization. So you have to find people and organizations which have this. And that's how you deliver more care, and you create a scale. Because for one hospital, it may not be possible to create a scale, but if there is a collaboration between multiple institutions, and that's precisely what has happened in CAR T cell therapy. It's been an effort which has been multi-institutional. Lots of public sector hospitals, private sector hospitals have come together, and that's how it has happened.
Sure. Now that's an excellent point. I think the points that we discussed about data being shared with the public sector, that's as relevant for the private sector, because the role of private sector in innovation and research is, especially when it comes to niche and quaternary care health, is probably underutilized right now. That can certainly be something that can change. I mean, thank you for bringing up that point. That's an excellent point. And now, so Shashank, the last part is, now when you actually did telemedicine in the past, when people were consulting this, you only had what a patient was telling you. But now you have access to a huge amount of data, like you're wearing a wearable. This kind of data could also be part of, a consultation, for example. So it is possible that telemedicine will give you vast amounts of data longitudinally on individual patients. So how do you think that is going to change the delivery of telemedicine? And secondly, is this information that could be more useful for, say, insurances to actually give a fair value to an insurance that is provided to a patient? Is that information going to be useful not just for provision of healthcare, but also for costing of healthcare?
Yeah. So what we have been seeing is that, as we have collected this information, we've been able to build a very strong AI that is assisting the doctor to doing the teleconsultation. In fact, I think Fortis had a quality summit in Bombay, and we got to showcase our product there, where we were able to show how when the doctor is consulting the patient, the AI is supporting the doctor. And there are three aspects to this AI. One, it is helping the doctor ask the right questions to get to the right diagnosis. And if the doctor is jumping to the diagnosis, it kind of indicates to the doctor that, hey, you've not asked these questions. For example, if he has a flu and he's jumping to which countries have you visited? As an example, if it seems to be a person who's traveling. Second is on the prescriptive side, and the third one is on the trust side. Even if you have the right consultation, right technical knowledge, but if the patient doesn't trust the doctor, he won't take the medication. So the AI that we have has actually learned from previous consultations and has understood that these are the words that a person from Bangalore likes to hear. These are the words that a woman of this age group like to hear, which increases the adoption of the medication or of the treatment. So doctors might not have that level of nuance. Of course, as they gain experience, these things are self-taught. But those are the insights that we've been able to gain and share it with the younger doctor. Right? And this has helped by quantifying it. So imagine you're talking to the patient, below there are 3 bubbles, which show you 85% accurate on the diagnosis, need to go further. On the trust side, you seem to only develop 70% trust. So speak for longer, right? Because this person likely wants 1 or 2 more minutes and has more questions, and you're abrupt, you're cutting the patient. Don't do that, because if you cut the patient, you might think you've given the right prescription, but the most important thing is the person has to go back home, trust your medication, take the medication for those long days, and then go forward. If they leave the consultation room with doubts in their mind, or that teleconsult, they're not going to take the medication. And then the prescription, right? And in the prescription, is it full or not? Again, in the prescription, how do you use AI to make sure that you're not over providing antibiotics? Why do you have to be commercially minded and see the second order, third order revenue streams, versus if that consultation is good enough, you build the trust so that you have longitudinal, what we call lifetime value for the consumer. So these are the 3 things that we have built that has helped doctors deliver better care. This is currently being used internally for our audit teams. We are now launching it for our doctors, and it will be soon also available to other, partners, hospitals, clinic. Anybody who wants to use it in the physical setting as well. That's one way we are using this information. And the second thing that we're doing is also with corporates, with payers, with them. We are also partnering with them to tell them that how can we reduce the unnecessary surgeries that are taking place. The use of triaging, right, is very, very powerful. And in many countries, the only way they've been able to keep costs down is by a very effective primary care network. In India, primary care networks are not, unfortunately, economically viable. And that's why they are all, So how do we create a primary care viable model? Can be digital, that way you don't have the physical costs, and triage it in a way that our ability to reduce the number of surgical interventions can come through. And so these are all the ways in which we are collaborating with payers. We are also collaborating with corporates, where this not only reduces their premium, because if you provide this out, you reduce premium, you're also able to improve engagement with employees, reduce absenteeism. So these are the conversations that and products that we have been working with corporates and payers.
Sure. Again, the counter for that is AI might reduce unnecessary surgery, but AI does not take liability if the surgery was life-saving, right? So I think that you have to also weigh both sides of the coin. So because one of the things that perhaps one of the criticisms of AI is that it gives a diagnosis, it gives you an answer, but it is not responsible for the answer. In fact, there was a JAMA study that came out just about 3 months ago about oncological effectiveness. And most people felt that the company that provided the AI solution should be liable if the medicine was not working. And clearly that didn't go down well. So that was the end of that. So I think we have finished in good time, so the organizers will be pleased with us. We have some time for questions, if there are any questions. So can we have some mics on the floor?
Hi, thank you for this wonderful session. So my question is for Mr. Shashank. Before that, I'll introduce myself. I'm Neha Tyagi, co-founder of Impeccable Innovations Private Limited. We are manufacturing gut-impacting health foods, right? So Mr. Shashank, my question is that how can companies like us, which are manufacturing health foods, can collaborate healthcare digital platforms like yours?
Can't hear you very well.
You can't hear me?
Yeah.
I'm not audible, is it?
No, it's echoing a lot. Perhaps just try without a mic.
Okay. Is it better?
Without a mic, yeah. Yeah, perhaps we'll just paraphrase the question.
So we're manufacturing health foods, right? Gut-infecting health foods. And my question is to you, Shashank, that companies like us, which are manufacturing health foods, how can we collaborate with digital healthcare platforms like yours?
I'm very happy that you asked the question. Actually, the problem in healthcare is that we are all talking curative. There is preventive and there's also peak performance, right? And the products that you're building, unfortunately, out of the $100 billion healthcare market that we have, 30-40 billion happens because of surgeries, right? And that's why we are all surgery oriented. But we really need to be in the preventive and in the peak performance, where products like yours will prevent the need for a surgery. My dad personally had 12 surgeries, and I think the way one needs to look at the future is how do you have least number of surgeries in your lifetime, at least before you're 30, 60, or maybe unless something genetics or something that you can't control. So I think your products are very relevant to obesity or will be very relevant to metabolic health, which could prevent the diabetes, hypertensiveness, which leads to many of these surgical cases. So I think, so what we do is we also have ability to showcase these products to our customers in the right manner. But going forward, we will be putting out a lot more products in the preventive and the peak performance space, where we want users to be more encouraged to prevent the need to go to, maybe the hospitals are left to treat the most vulnerable and keep people healthy as well. So that's something that we are doing. So we'll be very happy to take this conversation offline.
Happy to hear that.
Thank you. The gentleman at the back.
Hi, can you hear me okay?
Yeah.
Great. First of all, wonderful panel. Thank you so much, Dr. Sonal, Mr. Indu, Shashank, and Dr. Ashutosh. This is Swadeep here, Swadeep Pilari-Setti. Just a quick intro. I'm an engineer from IIT, but trained in the US in Georgia Tech and University of Chicago. I was a scientist for many years, cancer drug discovery as well as artificial heart valves. After a decade there, I came back to India. Now I'm investing heavily into medical devices and also healthcare AI solutions. Very close family member of mine recently, last month got diagnosed with advanced, stage 3 cancer, and interoperability might have solved the solution, might have solved the problem and caught it much earlier. If from a patient perspective, if he has access to data, or rather the radiologist had access to linear temporal data over time, maybe it wouldn't have grown to the point where it did before the radiologist caught it in time. In fact, it was caught much later. So I don't know if you know GFF when Mr. Nandan Nilekani, the CTO of India, right, who built Aadhaar, he was talking about tokens and how interoperability can help not just healthcare institutions, but the patient perspective, but also quick turnaround times for insurance, as you all discussed. How far is ABDM from not necessarily making it mandatory, as you said, like UPI has been, it's now almost ubiquitous because of the ease of use. If you can incentivize local states with either through finances as well as the consumers, how far do you think we are from making this almost like gold standard across the country? Is it even possible, or is it just like a unicorn in the cloud?
No, it will happen one day. Of course, see, UPI also is not mandatory. We all use UPI because we find it convenient. And even a street vendor uses that now. But see, the stories like that, what you told me, will actually encourage people to adopt ABDM because this kind of stories, interoperability, together with the AI, would solve many of the problems in terms of identifying diseases much earlier, having the pattern recognition, and providing you inputs in terms of what lifestyle changes or what kind of things one should be doing. And hopefully, with the evolution of all other innovations like IoT devices, which need to be interlinked with your health records, I think adoption will increase. And probably, it's like S-curve. I think we are still at the bottom part of S-curve, and I'm sure that as soon as we hit a critical number, it will exponentially increase. And will that be in 1 year's time? I doubt it. But will it be before 5 years? I'm quite sure about that. Within 5 years, we'll see a large number of, at least in urban areas, at least in middle class, people with the smartphones and some information about health system, they'll all be using ABDM compliant devices.
I hope so. It's not even AI, just basic access to all the records is enough. So temporal, right? That will solve a lot of problems.
We can take one more question.
Hello sir, I'm Amit, founder from MXSCI. At MXSCI, we have a product in healthcare. So we build patient-side AI agents and the doctor-side AI agents. The patient-side AI agents can book appointment, file insurance claims, and also collect the symptoms, what they have to talk on the patient side. And it helps the doctor-side agent. Doctor-side agent is give assistance to the doctor. So it gives the symptoms along with whatever the patient had talked to the patient-side agent. Also it gives the medical history so that it helps doctor to prescribe that it has these many of disease. I'm coming from a technical background. I'm graduate of IIT BHU, and then I worked with tech companies like Microsoft. But the healthcare is something new for me. So my first question is that how can I collaborate with the leaders in healthcare and build some innovation. And the second question is that we need to pick a niche. So as of now, we thought that let's do it in psychology. So maybe we can gamify something or plays something music or like whatever they like, whatever their persona can collect the information. They can reduce the stress and all. So which field would you suggest as that this would be the best domain that you can experiment and do the innovation at very fast?
Dr. Ashutosh, do you want to take that? Because
Yeah, I think there are several platforms where you can engage with the healthcare providers and other ecosystem companies. Nat Health, for example, has a yearly event where they have a hackathon kind of event, and there are FICCI and other organizations like that also from time to time have such events. I think you can participate in those, and those are the areas where, identifying a problem statement and addressing it happens generally by serendipity and, chance. I think you will have to find that story for yourself.
Yeah, I can add, given that probably I was in your shoes 16 years back, I can tell you that, there are two set of, there are clinics and there are hospitals. Starting off at clinics reduces your sales cycle and your iterative cycle. So I think the therapy line you're choosing is one of those in that clinical space. But I would say that there are two others that you could think about. The only reason is in the space that you're talking about, it takes 1 year for the recovery, for the, as a therapist or as a psychiatrist, that's the timeline it takes unless there's in-house admissions. So the other two domains you could look at is dentistry and dermatology. And so because the practitioner is also the caregiver, the caregiver is also the owner of the setup. The iterative cycles are faster and the adoption rates are better when you start off with. So, and because they're procedural oriented, your ability to showcase monetary benefits to them is faster, which will then lead you to be able to do it for many more. So just as maybe, from my personal experience, this could be to start with. And then, of course, you go into other therapy lines as the success of the models determine.
Sure. Thank you so much to the wonderful panel. You've been wonderful. And thank you all to the audience for your patience after.
Well, ladies and gentlemen, with that, let's give a big round of applause for our dignitaries on stage for such a fantastic session. Thank you for sharing all the valuable insights. I would now request Himakshi from Knowledge Partners, BCG, to please join us on stage and hand over memento to all our dignitaries on stage. Well, also, ladies and gentlemen, we would just like to remind everyone about today evening. We have the program starting up from 6 p.m. onwards at the plenary hall. Well, we request everyone to join us for the SME Connect Award ceremony, which will be held from 6 p.m. onwards, followed by a dinner hosted by Shri Sharana Basappa Darshanapur, Minister of Small Scale Industries and Public Enterprise. Well, let's give a big round of applause, ladies and gentlemen, for the dignitaries on dais for such a great and insightful discussion. I'm sure everyone thoroughly enjoyed this entire session. We wholeheartedly would like to appreciate all the dignitaries on dais for their valuable time.